Relations using telemedicine. So thank you everybody for being here. And just a few housekeeping notes. All of your participant microphones are muted. So if you have any technical issues, you can use the tech support chat pod on the bottom right side of your screen. We will also be collecting questions from the audience throughout the presentation. So whenever those come up, feel free to type your question in, and we will have some time at the end for some discussion and answering audience questions. So the Transdisciplinary Collaborative Center is funded by the National Institute for Minority Health and Health Disparities. And we have two main components of the work that we do here. We have a research focus to inform policy about the impact of health information technology on health disparities. And we have a practice focus where we are trying to implement those policies and the research findings to advance health equity in practice. You should be able to click on that link to visit our website and follow us on Twitter. The learning objectives for today's webinar are that by the end of the session, the participants will be able to describe how telemedicine is being used to increase access for underserved populations, to examine some policy and practice factors that influence telemedicine adoption and utilization, and we will review a practical example of how telemedicine is being used in the community to advance health equity. I am really excited to have two speakers with us today, and unfortunately it looks like Anitra might have fallen off, but we'll try to get her back up here as soon as possible. We have Sherry Williams, the Executive Director for Georgia Partnership for Telehealth, and Anitra Walker, Director for Behavioral Health with Mercy Care. And I'm going to start by providing kind of a high level framing some of the issues that we're going to talk about today, and then I will hand it off to Sherry, who will talk about what Georgia Partnership for Telehealth does and give us kind of an environmental scan of the telemedicine environment in Georgia. And then Anitra will talk about some of the work that Mercy Care is doing using telemedicine. So just to start out with the definition, a very basic definition of telemedicine is the delivery of healthcare services over distances using telecommunications technology. So this is, you may often hear the terms telemedicine and telehealth, sometimes used interchangeably. The distinction that I draw for myself in using those terms is telemedicine really refers to that delivery of healthcare services, whereas telehealth encompasses a lot of other things in addition to delivery of healthcare services. And some of that even being distance learning and distance education. So telemedicine is really specific to that delivery of care. And we'll definitely hear from the other speakers today, but telemedicine can be used for many different applications. Primary care, it's being used, behavioral health, dermatology, stroke and triage, intensive care, and school-based health are just some of the ways that telemedicine is being used. But I definitely hope that as an audience throughout this presentation, you're thinking about telemedicine and potential uses very broadly, because the sky really is the limit with that. So the impact on health equity for telemedicine is really great, and it's a really exciting technology as far as that impact on health equity, because really by definition, by nature, it is a technology that can be used to increase access by bringing services to populations where they may not otherwise be available. It also has a huge convenience factor, which I think is one of the things that is also driving the popularity. So for patients who are using telemedicine, it can negate some of that taking time off of work, decrease the travel distance and time, and it's also a way to engage patients. So I think it's beneficial to look at it from, again, that broad perspective and what all can we do with telemedicine. So you may be able to see your patients more often than you do face-to-face and do more regular check-ins. It's also a way to do a lot of that care continuity and coordination that is challenging to do in person. And then from our perspective within the National Center for Primary Care here at Morehouse, increasing primary care capacity is some huge potential with telemedicine, and things like Project Echo, where the whole goal is to provide primary care physicians with additional skills so that they can decrease referrals to specialists or utilize those referral situations when they're really needed, and in that way also increase access. And then just some statistics on utilization of telemedicine. So we are hearing a lot about it. Policymakers are talking a lot about it. And it's actually not something that's new. It's been around for a long time. And in fact, Medicare started reimbursing for telemedicine in 1999. But we are still seeing a gap with actual utilization. So data from 2012 reported that 42% of U.S. hospitals were self-reporting telehealth capabilities, but we don't know how many actual encounters and how much of that data was actually flowing with those numbers. We know that in also 2012, the Medicare expenditure was $5 million, which is under what was expected and what was allowed through the Medicare program, and 70% of those claims were for behavioral health services. And then this is some of the research that we've conducted, and we looked at over 33,000 Medicaid enrollees in 2008 and 2009 had received telemedicine services, which was equivalent to 0.1% of all Medicaid enrollees in that time period. And 90% of those claims were for behavioral health services. So as you can see, behavioral health is something that it's really being used a lot for, but we will talk about some of those other applications as well. And then just some of the policy issues. Sherry will get into a lot more details with this, but when we're talking about telemedicine, we're talking about policies that impact the practice of medicine or define the practice of medicine using telemedicine. And then we have payment. So that's always the big question that we hear from providers who are considering adopting technology is how are they going to get paid for providing these services? So most of the policies listed on this slide are state level policies other than the Medicare, which you see with the asterisk there. So Medicare does pay for telemedicine, but has some very strict limitations about where those services can be provided and what services. Medicaid obviously varies by state and private payers. For example, in Georgia, we do have a private payer mandate so that private payers are required to reimburse for services that are delivered via telemedicine as they would in face-to-face. Now we do know that practically that is not always the case that happens, at least that the equivalent amount of money is reimbursed. And then there are some licensure issues too, and states deal with licensure for telemedicine in a lot of different ways. Some of those being granting multi-state licenses to physicians so that they can practice within that state. And some states even have telemedicine-specific licensing laws that allow out-of-state providers to practice within the state strictly telemedicine. So I'm going to hand it off to Sherry right now to talk about Georgia Partnership for Telehealth and what's going on in Georgia with regard to telemedicine.
As Megan said, I'm Sherry Williams. I'm a licensed clinical social worker. So a lot of what I talk about comes from a mental health perspective, but I'm also the executive director for Georgia Partnership for Telehealth. Over the past couple of years, Georgia Partnership for Telehealth has expanded quite significantly. We have a not-for-profit in Georgia, Alabama, Florida, and then we're part of the federal Southeastern Telehealth Resource Center program. So there's a lot of logos. So we rebranded ourselves. We are a global partnership for telehealth. So if you have heard us called any of these other names, I just wanted you to know that they were the same. We are headquartered in Georgia, but we do touch a lot of regions outside of our state and also internationally. A lot of times people want to know what the role Georgia Partnership for Telehealth plays in other companies that are similar to us. We are essentially the conductors of telemedicine. There's a lot of moving parts in telemedicine. Our particular company, we do not employ physicians, but we partner with physicians. We have approximately 600 or so endpoints just in the state of Georgia alone. So that's a lot of moving parts. So we're the traffic controller in the background. We control schedules, we control who's connecting to who, credentialing, scheduling, all of that good stuff. So I like to make sure everyone understands what perspective I'm talking from. This is what our network looks like. It's an open network. If you think of a spider web, once you are connected in our network, you can connect to anyone else in our network. So those 600 endpoints in Georgia can easily connect to each other without any barrier. This is what we look like in Georgia. This map is a little bit outdated. It kind of shows you how telemedicine is spread throughout. Atlanta and the metro area is heavily inundated. Obviously, our goal when we first started Georgia Partnership for Telehealth was to reach the rural areas of Georgia. And unfortunately, the rural areas of Georgia do not have access to specialty care that we can find in the metro areas. So all those little dots that you see scattered throughout Georgia are our presentation sites, and then the metro areas are heavily inundated with specialists, so we're connecting back into those areas. As Megan said, telemedicine is boundless. We tell people if you think it, you can almost do it in telemedicine. We see a lot of different environments happening in our network. Primary health care is pretty big in our network, as well as the behavioral health piece, and I kind of lump those two together. I agree with the statistics Megan showed earlier. Most of what happens in our network is largely mental health and behavioral health. And I always preface it by saying that just because telemedicine enters your world doesn't mean that there's just an overabundance of psychiatrists and mental health professionals to go around. There's a shortage in psychiatry, regardless if it's in a traditional method of receiving care or through telemedicine. So I always like to make sure people understand that. Some of the other applications that we're seeing, skilled nursing facilities do a lot of mental health and wound care in our skilled nursing facilities. School-based health centers is an area of tremendous growth that we've seen over the past few years. Specifically, probably in the past 18, 24 months or so, school-based health have exploded in Georgia. I think we are right around the 90 mark with school-based health centers just in our state, and then Tennessee has also started adopting telemedicine into their school-based health centers, and we work with them on that as well. Ambulances and paramedicine, and there are several hospitalists. They're just unserviced in that community, especially if these people that are being transported are non-emergent, and we have an emergency comes in. We've had lots of cases where people have died waiting on the ambulance to get there. So the paramedicine program essentially serves those patients who call 911, EMS arrives, they triage the patient, and it's just not an emergency. It could be an ear infection, toothache, anything like that. Telemedicine is very appropriate for that. So with the patient's permission, those are turned from a transport to a telemedicine visit. The ambulance is staying in that county waiting on the next emergency to come in. So that is something that is in a pilot phase now. There are some wrinkles to iron out, but it looks like it's going to be a fairly successful program, and hopefully we'll end up saving lots of lives. A lot of people want to know what a telemedicine site looks like. It looks like a lot of ways. This picture just shows you one of many, many examples, and you can see this is a traditional telemedicine cart. For years, this was the only type of a solution. It was a full cart. The price range on it was $30,000 to $40,000. That is no longer the case. The prices have come down tremendously. There are very small and simple solutions that are as small as your PC or your laptop or your tablet. So telemedicine can look 100 different ways in 100 different environments. These are some images. I like to do a live demo, but through the webinar, a live demo is kind of difficult to do. So I'd like to show you some pictures of some of the images that we've through telemedicine. The first one is a picture of an eardrum, and if you see that little tiny thing in the bottom, that's actually a bug. It's a gnat, and that's one of our employees here at GPT. He fishes a lot, and when he came back from fishing, we were just testing out some scopes that we had received in, and we found a little bug in there. So that was kind of a cool picture, and it really shows you the capabilities of telemedicine and what you can pick up in these images. This is just another slide of eardrums. We have a fairly normal eardrum. You can see some redding across the top of the top left image, and then the top right image is an eardrum of a child in one of our local schools here. Came into the school nurse, tugging at the ear, just complaining, had a difficult time hearing, it was hurting. She puts the scope in his ear, the school nurse puts the scope in the child's ear, and yes, which she had no idea what that was. She thought it was a spider or something that had crawled into the child's ear, but it's actually hardened, impacted earwax. So through telemedicine, they were able to determine that, and the child was able to have his ears cleaned out and went on to have a healthy ear. The impact of telemedicine is pretty obvious in my opinion. If people can stay within their communities to receive care that they otherwise would not be able to access, they're not driving a long distance to get to specialty. I happen to be in South Georgia, so for residents in South Georgia, we frequently drive to Macon or Atlanta or Augusta for medical care. That's a 3 to 4 hour drive away. So we're looking at a full 8 hours if we go to Atlanta and back. That's a parent missing a full day's worth of work. That's a child missing a full day's worth of school. By providing telemedicine, we're able to access these things locally, keep people local, and support the local resources. If you are driving to Atlanta for a doctor's appointment, there's labs that have to be drawn. Chances are you're going to stay in Atlanta and have those labs drawn rather than using the local services back home. So the local medical community like it because it does keep patients at home. And it keeps them engaged in what's happening in the local community, while at the same time they have access to these wonderful specialties that are available throughout the state. I'll talk a little bit about reimbursement and regulation, and I will preface this by saying that I will be talking largely about the state of Georgia. Some of you on the call may not reside in Georgia and may have questions outside of the state. At the end, if you do have a question, if you'll just type it in the chat box, I will do my best to answer regulation questions outside of the state. And if I don't know the answer, we can certainly get it for you. So one important thing to consider if you're doing telemedicine in the state of Georgia and you're a physician, there's the Georgia Medical Composite Board that you need to go by, the regulations. About 2 years ago, they adopted telemedicine language. And this first slide shows all the musts. You can see each of the bullet points are followed by the word and. So you have to have a Georgia medical license. There are some across the nation. Several states are buying into a telemedicine compact license. Georgia has not bought into that. So if you were doing telemedicine in the state of Georgia, you have to have a current Georgia medical license. You have to practice within your scope. That kind of goes without saying. You have to have patient history available. If I'm going to refer a child to you as the physician, I've got to supply you with some type of medical history on that child. And then on the next slide, you have to meet at least one of the following criteria. And each one of those is followed by the word or. The very last bullet point is the one that I like to really point out because I think it speaks a lot to what the state of Georgia has tried to do with this language. So if you're going to do telemedicine, you have to be able to complete an exam that is equal to or superior to a traditional visit. That means if somebody is complaining of a sore throat, you have to be able to visualize that throat. If there is an issue with the ear, you have to be able to visualize that ear. The state of Georgia really worked hard on this language. We went back and forth with the composite board. We didn't want it to be so regulated that it made it difficult to do telemedicine, but at the same time, I think everyone agreed that there needed to be enough there so that telemedicine was still done in an appropriate and responsible way that it holds the integrity of medicine. So if you're not familiar with these rulings, I suggest that if you're doing telemedicine in Georgia, that you understand what the composite board is saying. Reimbursement is, Georgia is a very telemedicine-friendly state. Back in 2005, the Georgia Telemedicine Act was passed, and that act put forth parity law. Parity law essentially says that if you're doing telemedicine in Georgia and you're an insurance company and a physician submits a claim for telemedicine, you have to reimburse it dollar for dollar what you would reimburse for if that was in a traditional visit. There are caveats to that. There's always a caveat to everything. So the caveat would be Medicare. Medicare has their own set of rules that we'll talk about in a few minutes. And some of the self-insured policies can write in whether or not they want to cover telemedicine. It is my experience that more times than not, telemedicine is accepted across the board. There's been a few times with some smaller companies, and this was several years ago, that telemedicine was not written to those policies, and it became very difficult for those members to receive care through telemedicine. And I think that is an education issue. I think telemedicine still is fairly young, even though it's been around for years and years and years. I've been doing it here at Georgia Partnership. We've been doing it for a little over 10 years now, so it's not brand new. But in the whole scheme of things, it is somewhat new. I think people don't necessarily understand what telemedicine is. You can ask 10 people to describe telemedicine, and you're going to get 10 different descriptions. Our description at Georgia Partnership are those images I showed you. You have to be able to look and visualize various body parts. You have to be able to listen to heart and lung sounds live time. Other people see, a simple phone call or a flat video, some like what we're doing today and interviewing back and forth. So with education, reimbursement has gotten better in our state. Back in 2012, DCH, the Department of Health in the state of Georgia, created the very first telemedicine handbook, and it went through all the rules and regulations that they required for telemedicine to be reimbursed. It clearly defines who is eligible to bill through telemedicine, where appropriate telemedicine settings are. That was revised earlier this year, so if you have an older version of the DCH manual, you may want to go and make sure that you've updated to the 2016 version. Some of the locations in Georgia that are approved, hospitals, FQHC, school-based health centers, health departments, and that list goes on. CMS is very, very different. They have very different guidelines. And my advice to you, if you are going to do telemedicine and you're going to bill Medicare, the address of where that patient is matters. So before you engage in a relationship with a patient through telemedicine, about 8 years now. And recently, within, I would say, about the last couple of years, we've been doing this program called Street Medicine,
where we actually go out into the streets where our patients are to try to offer medical care. So I'm going to kind of go through a little bit of what Mercy Care is, and then a lot of what we've done with telemedicine out in the street. Okay, someone can't hear. Can you hear me at all? Okay. I will try to talk louder. All right. So Mercy Care is a federally qualified health center. Here's a list of some of the different services that we offer. Our main service, of course, is our primary care. We focus on a lot of chronic diseases. And what makes Mercy Care a little different is that we actually have the Healthcare for the Homeless grant, and that allows us to really focus on the homeless population. I think last year we served about 60%. 60%, I'm still trying to get my volume up, 60% homeless population. So they're a big part of our focus. Some of the other specific programs we do are related to infectious disease. We have a whole primary care devoted to HIV, individuals who've been diagnosed with HIV but need ongoing primary care. And recuperative care is a 19-bed facility at a shelter location where we take patients leaving a hospital, well enough to be discharged from a hospital, but are homeless and would likely relapse if they were placed back onto the streets. So we take those folks in and offer them services. We also do dental, vision, x-ray, and what's my world is behavioral health. And that's where kind of street medicine was born out of. You can also see just a little blip of our budget, and we're really an unfunded program for the most part. A lot of our patients are uninsured, so about 6% comes from patient revenue for what covers our total cost. So Telestreet medicine, there were two main purposes in us doing it. One, to try to really expand primary and subspecialty healthcare to folks living under bridges, out in the environment. We really wanted to focus on the unsheltered. So even not the folks living in a shelter environment or in transitional housing, but really focusing on those out living in the streets from day to day. And it was also a way for us to encourage providers to volunteer from the comfort of their own home or their own office. So get more providers out there to get interested in this type of service and do it in an environment that was easier for them to do from. So just a little logistics. We go out typically one evening a week to the streets of Atlanta. Our team consists of those folks there. We've got really important on the team is our outreach RN. She kind of is the glue that holds the whole team together. A lot of scheduling and figuring out which patients we need to follow up with. Another really important member is our outreach guide. This is a person who has been previously homeless, and he really understands the streets. He's our guide to the streets. He lets us know where we can go, where we can't go, where the hot spots are, and those kinds of things. And then we've got our providers, our psychiatrists, our PCP, and we've got a few students from some local universities that we've partnered with. We also go out once a week on the afternoons with another outreach team, and we connect to the psychiatrist via telemedicine. So a little bit about client engagement. It's really important not only for telemedicine in general is a challenge to really engage folks and get them comfortable in receiving care from this type of medium, but also the folks that we're serving. If you can imagine, we're serving the truly vulnerable, really marginalized from society and very untrusting of a lot of society. So trying to engage those folks is a challenge at times, and a lot of times we'll bring out different things like hygiene kits, food, just things to really get them to feel comfortable in meeting with us.
No, absolutely. So I'll start off by saying telemedicine is not a situation where you build it and they will come. Telemedicine is great, it is fabulous, it is very sophisticated, but if you are not serving a need for your community, no one's going to use it. So the first thing to do is do a needs assessment. Where are your gaps? What are people having to leave your community to go see, or having to leave your practice to seek out? And can telemedicine fill that gap? And a lot of times I think the answer will be yes. So once you've identified that area, then you really need to get down to the nuts and bolts. What is your, consult your IT people. What is your bandwidth? If you don't have good bandwidth, you're not going to have a successful telemedicine program. And you have to have a champion on your site that is going to run the telemedicine program. If you have a nurse or an administrator or whoever that person is, fill in the blank, that is not supportive of the program, they're not going to want to use it, and they're going to refer people outside of the telemedicine realm. So make sure you have a champion. Make sure you know what problem you want to address, and then make sure you have the infrastructure to support it.
This baby had been born, and it was kind of this moment where they connected and felt like they were a part of each other's lives, from this person going into the homeless individual's homes, in a sense, on the street, and then them also getting to see Dr. Bamra in her home with her baby and kind of her lifestyle as well. So it was a way that we kind of helped to build that engagement and build that trust in a different way that you really can't do in a clinic setting. Here's a little bit of the workflow for our street outreach. Typically, so they're out on the street, the RN will notify the provider if there is a patient that needs to be seen. We do have an electronic medical record. We use Epic, where they'll log in, they'll check the patient in, they'll do all of the routine stuff that you might typically do in a check-in at an office. And then the student RN will obtain further consent. We have a form that the patient reviews and signs. And the student will also get the H&P and then present that to the provider via the telemedicine.
Sure. And this is where Georgia Partnership comes into place, and this is what we're very good at. As I mentioned earlier in my talk, there are lots of moving parts and pieces to telemedicine. In our particular case, there's 600 endpoints with 600 schedules and 600 people trying to do 600 different things. So there has to be a coordination piece. One of the things that we offer at Georgia Partnership is a central scheduling component. So we manage probably about half of those that are in our network. We manage their schedules for them. It's just a lot of scheduling. Some people that want to only connect to one or two locations, and they're not opening up themselves to the entire network. They have no desire to work with 600 people. Maybe they only work with 2 or 3. That scheduling is easy to manage, and they usually can manage that on themselves. But those who are opened up to our entire network, which is a lot of our network, we manage that.
And then for our
when we're talking about workflow in a practice,
the main difference
there's a number of ways I've seen it work.
When
we're talking about physician schedules, sometimes physicians want to block off time. They want to have telemedicine clinic days, especially our specialists. Mental health, we do some pediatric GI stuff, and lots of other specialties. Those doctors want a specific schedule. So, for instance, every Wednesday from 9 until 12, Dr. Smith knows that he or she is going to be sitting in front of the computer doing telemedicine for 4 hours or 3 hours or whatever. Other doctors like to work it into their schedule as a walk-in basis, especially primary care. The doctor is there, he walks into exam room 1, sees the traditional patient goes to the next exam room, sees a traditional patient, goes to the next exam room, and sees a telemedicine patient.
So just to give
And
you a
it just
picture
works
of
into the
the
workflow that
equipment
way.
that we use.
So I've seen it both ways, and it works
because
both
we
ways.
have
It really
the
depends
primary care
on the environment
providers
and the
as part of
climate
our
in that
team as
particular
well.
practice.
We've got a lot of the scopes and things like that you can see there. We have the HP notebooks. Mostly on the street medicine team, though, they're using the Surface Pro tablets. We've found those to be great because they're so lightweight and just mobile for us to use, which a lot of you probably know what that looks like, but it's similar to an iPad for those of us that use Apples. And then we've got our MiFi with us as well, so we can be connected to the internet out in the field. So here's an idea of our numbers. On average, we have just
everything that you said. That's how it works. So in some examples, we have a couple of very large hospitals in the state of Georgia who see patients from everywhere.
For example,
when they started their programs, they sort of wanted to tiptoe into telemedicine. They didn't want to be open up to any and everybody in the network right away. They wanted to really develop a protocol and a procedure and a process for how it was going to work. So they went through their existing patient load, and they knew that in the next 30 days, 4 patients from South Georgia were going to be driving in to see them. So rather than those patients driving in, they offered those patients a telemedicine option. So that is one way that I've seen it work very, very well. Others come to us, they feel that telemedicine is how they want to start
primary care providers available,
turning their practice around, or maybe they're wanting to get out of the traditional primary care setting and they only want to do telemedicine. Those physicians usually are not selective with who they see. They'll see whoever we send to them, and we get referrals from a lot of places. School-based health centers make a lot of referrals to us. We get referrals from patients themselves. We get referrals from doctors who are not doing telemedicine but know that telemedicine is available in their community and they want to refer a patient to a specialist. So our referrals come in from various places, and then we work with those particular providers to match them up.
Especially when you have a new
we know
baby at home,
which physicians take what payment sources. We know, the criteria that the patient, that the physicians have. So we match those patients up with the physician that would work best with them.
Volunteer your time when it's easy for you to do. It's also, we did a few surveys and found out that it is high level of consumer satisfaction. I don't know the total scores or the average score that we received, but I know that the scores were very high for those that we served. And part of it, too, as a success, was making it through a lot of the challenges and frustrations.
Exactly, and it goes back to that planning. When you begin your telemedicine program, kind of have an idea of what you want to do. Even if you're a primary care doctor and you may want to refer to 10 or 15 different types of specialists, go ahead and know what those are. Who are you referring mostly? Are you doing a lot of nephrology referrals? Are you doing a lot of mental health referrals? And then come to us with those and let us start working in our network with the physicians that are available and start matching you up so that when a patient does come in, that doctor is waiting for you, and it's not a, oh my goodness, we have this patient, now let's hurry up and find a doctor to fill in that gap. Much better and works much more fluently if you have those providers already in place.
Working together. What I learned from all of this was we came together with Georgia Telehealth. They were able to really kind of provide us some direct service, some hand-holding, figuring out with our IT people that are trained to do this job. They were able to really figure out what the problems were, what we needed to do differently so that we could make sure the connectivity and some of those equipment software issues were resolved. There were some workflow issues in the beginning.
You saw the map
excitement and kind of gives off the idea that everyone's doing it, but we know that there is that gap with utilization. So what are some of those factors that are contributing to that gap, and where do we really need
to have a wonderful telemedicine program? But literally, we had this situation about a year ago on the 3rd floor of one of our hospitals. They had a telemedicine program that had been up and running for a couple of years. Very
grooming people to so that they can be.
That's okay. And directly on the second floor, literally, the telemedicine suite is here, and directly underneath is this physician. And this physician underneath on the second floor wants to do telemedicine. So he reaches out to us, hey, I want to buy all this equipment, I want to do this, da da da. And we're like, wait, do you know that on the floor right above you, there's a wonderful, beautiful telemedicine suite that you can book time in and use? He had no idea. I think lack of utilization is comes in large part from communication and marketing the program. If you are separated literally by a ceiling and a floor between you and a telemedicine suite, there's really not a good excuse for either one of you to know that the telemedicine department should know that that physician has a desire to do telemedicine, and that physician should know that telemedicine is already available at that facility. So there's some disconnect there. We also have a hard time reaching the general population. We do a great job of reaching out to the medical community and marketing telemedicine and educating about telemedicine, but it's not so easy to reach the general consumer. Megan and I have had this conversation several times. How do you reach the general community? You know, we do as many television interviews as we can to make sure that telemedicine is talked about. But we really have a problem making sure that that general consumer knows that telemedicine is available, knows that they can ask their physician if they're being referred to a specialist somewhere, is telemedicine an option for me? And if so, how do I access it? So I think we have to reevaluate what's happening, the reason for underutilization, because there is a tremendous underutilization problem. And then we need to attack it. And I think getting to that general consumer probably would be the #1 remedy in getting people in front of the camera and using telemedicine.
Right, and yes, we have had a number of conversations about that, and wanted to draw the audience to some of the videos that we partnered on with Morehouse School of Medicine, Georgia Partnership for Telehealth, and Mercy Care, and we created an animated video that kind of explains telemedicine from a patient or consumer perspective. So what is it? How do you get it? In many states, insurance reimburses for it or covers it. So ask your healthcare provider if they are providing telemedicine. And the ones with Mercy Care talk about some of those specific situations with the patient engagement and the physician that Anitra mentioned earlier, and making that connection, and focuses on the street medicine program and how great the work that they're doing is to advance health equity with that use of telemedicine. So I think we're having technical issues because I also haven't seen any questions in our chat box, which surprises me because usually our audience is relatively engaged in asking questions. So I'm going to assume we're having some technical issues with that. So let's talk about that one last question. You did talk in your presentation about reimbursement, but I would like to get a little bit more specifics, especially with behavioral health, since we are seeing so much utilization with that. Can you talk about how, at least in Georgia, some of those behavioral health services are reimbursed for, and if there are ways that we can advance the policy to support the services that we want to be providing and getting paid for?
And as an LCSW, I will raise my hand and say, you know, LCSWs, LTCs, LMFTs, all of those wraparound services should be able to be reimbursed for telemedicine. And I think in a lot of times the reimbursement is occurring. I know that there are some social workers and some MFTs and some LTCs that are using telemedicine as a way to reach their clientele. And in some cases, reimbursement is occurring. It is it has not been a policy at this point for it to be officially reimbursed. So I would love to see, from a mental health standpoint, all of these ancillary and wraparound services become a part of it. I have been involved in many mental health encounters, and almost without a doubt, that physician is going to prescribe for that client to receive counseling services. Well, you know what? A lot of times that patient can't find services. There's no services available in that community. They can't drive elsewhere. They're not comfortable going somewhere else. They like the environment of the telemedicine encounter. It's less intimidating. It's easier for them. I think we will see a lot better outcome when we're able to provide wraparound services, and that's a reimbursable service. And I think we're going to see satisfaction on both the provider and the client side. In terms of just general reimbursement for mental health, it's pretty easy. If it's listed in the DCH manual as an approved service, it's as simple as billing your traditional CPT code with the letters GT on the end of it. So if you're billing 90801, it would be 90801 GT. The GT just sets it apart as a telemedicine encounter. Usually that's for data purposes. I think when we're looking at the data that Megan presented earlier, it looks like there may not be as much telemedicine happening as really is. I think many times the billing departments don't add the GT modifier to the end for whatever reason, lack of education. I don't know why the GT modifier isn't always added, but I think there are probably a lot of instances where it's not. So there's probably more telemedicine happening than we actually know about. But with that GT modifier, especially in the state of Georgia, reimbursement should not be an issue. If you're brand new to telemedicine and it's the first time you are billing a CPT code with a GT modifier on the end, you may get a denial the first time, and usually when you resubmit that, it goes through without a problem.
Great, thank you. So it looks like our time is up. I want to thank you, Sherry, and thank you, Anitra. I don't know that we were ever able to get you back up, but thank you to our audience as well for joining us. And if you have additional questions, you'll be getting some post-webinar emails, and please feel free to reach out to us with the TCC at Morehouse School of Medicine and to Sherry at GPT. So thank you, everyone, and have a great afternoon.